Good day, and thank you for joining our webinar, Advancing Health Equity for Underserved Populations Through the Use of Digital Health Tools. Our presenters today are Mitchell Blunt and Rashira Dobson. Today's objectives are assess the utilization of digital health tools by primary care clinicians and people with disabilities. Identify barriers to facilitations and use of digital health tools in primary care settings and in the underserved population groups. Inform local and state level policymakers, clinicians, and stakeholders on multi-level interventions that will support the implementation and use of digital health tools to advance health equity beyond the COVID-19 pandemic. I'm going to turn it over to Mitchell Blunt. Thank you, Mitchell.
Thank you, Selena, and good afternoon, good morning, depending on where you are, everyone. We're just so happy that for this opportunity to be able to talk with you today. So as many of you are already aware, but we are Morehouse School of Medicine located here in Atlanta, Georgia, and we're one of 4 historically Black medical schools and universities in the nation. And our vision is leading the creation and advancement of health equity. We also represent the National Center for Primary Care. And so the National Center for Primary Care, or NCPC, as you will hear it referred to throughout our presentation, serves as a national resource for clinicians, practitioners and educators, researchers and policymakers who impact our primary care health center. So we are here to talk to you today. I will start off talking about our digital health tools study, as Selena mentioned, and Rashira will follow up with another study on our Telehealth Disability Study. So our digital health tools study builds upon previously conducted research. This study has been conducted right now through a partnership with the United Health Foundation. We were awarded a 3-year grant to assess the adoption and use of digital health tools by primary care clinicians in the Southeast, with a primary focus on Georgia, North Carolina, Kentucky, and Tennessee. We know that primary care practices, especially those that are serving underserved communities, have really struggled to adopt and use digital health tools, and especially such as electronic health records and telemedicine, and serve those patients in those high risk and high underserved populations. These gaps that we have been identified severely limit the benefits that digital health tools can really have on impacting those communities and advancing health equity. So we employed a multi-method approach to identify the barriers and facilitators to digital health tool adoption and use at multiple levels. So we assessed at the individual, the clinician, the practice, the population level, and looked at some system and policy implications as well. So you will hear us refer to digital health tools as DHTs, but we just wanted to actually just define what we mean by digital health tools. So when we are discussing it, you will hear referred to as telemedicine, home remote monitoring, patient portals, HIEs, electronic health records. So we conducted 7 focus groups and listening sessions with 25 clinicians to have more in-depth conversations about the use of digital health tools, including barriers and facilitators to use. All of our sessions were recorded and were analyzed by our qualitative analyst team, really to identify some key themes in each focus group. As you can see from this slide, most of our focus group participants, clinicians, represented and participated and served in community health centers. So just over 50% of those, followed by our large practice in hospital and outpatient primary care settings. The majority of those clinicians were MDs or DOs, followed closely by our nurse practitioners. They were mostly in primary care or family care settings, with most of them having experience less than 10 years, and just over 95% actually accepted Medicaid. So you will see a couple of images on this screen. To the left is a word cloud, and this word cloud really represents a lot of those thoughts and themes and conversations that came out of those conversations with our clinicians. So we heard from clinicians via our survey from across multiple settings. Thank you. specialties, years of experience in practice. We really heard that, telehealth is something that really needs to be tailored to the individual. It is not a one catch-all for patients nor clinicians. We've heard one participant say for them, it's not really about the technology, it's who's on the receiving end of it, how well that relationship is and how well it works and what the families get. So the clinician really is stating that technology is important, but it's more about the relationship that you develop with that patient that really advances health equity and advances their care. So for our clinician actually surveys, we heard from clinicians via an electronic survey that we deployed via RedCap from multiple specialties, years of experience and practice. We collected a lot of demographic information, race, age, credentials, and use of specific tools. And again, here you can see the majority of our clinicians practice in large practice settings, large hospital and outpatient care, primary care settings, and community health centers, with good representation, smaller representation, but in our solo private practice and our small practice settings. So looking a little bit more into actual digital health tool usage, almost 99% of our clinicians had used some form of digital health tool within the last 5 years. Most of those tools that the clinicians used were EHRs, telemedicine, and patient portals. Telemedicine specifically was used primarily by those in practice specialties in family medicine, MDs, and practicing in a federally qualified health center. As you can see from the image in the middle, a little over 65% of our clinicians were satisfied with their telemedicine experience, but that means 40% weren't. And so some of the dissatisfaction that we heard in response to some of those barriers were time and overhead costs, limited workflow integration with their existing tools, so having to adapt to a new tool and then integrate into that system. Low reimbursement from payers. So at the time, some clinicians weren't getting reimbursed fully for the type of appointments they were having, and lack of autonomy in decision-making. So we heard from clinicians that they had no choice in the types of tools that they use and how to implement them. On the right side, you can see our top 3 barriers to adoption. Again, time and cost and limited workflow integration. And then some actual supporters. For some, it was easy for them. We heard that a lot from those that were in large practice settings. It meets the patient's needs. So telehealth was very important at providing patient care, and it improved the patient's health. So digging a little deeper, just looking at the specific tool usage by clinician, we saw that telemedicine was used very highly among those in those solo private practice and small practice and community health centers. Most of them were female and within their 40s. A lot of them were eager and early adopters. We saw that almost 4 times of the clinicians were pediatricians, which was very interesting. And 2 times as many clinicians who use telemedicine compared to any other specialty use it for behavioral health, which again, we are seeing that is very important right now. So for our clinicians who use electronic health records, the majority were nurse practitioners or physician assistants, and almost 2 times more likely to be of Hispanic or Latinx descent. When we're looking at the health information exchange, almost 2 times, again, more likely to be Hispanic or Latinx clinicians, NPs or PAs. And we really want to highlight that 76% of our respondents stated that they were connected to their state HIE, yet almost 41% of those respondents stated that they were using it. So there were some discrepancy in that. So they may be connected, but the usage of it has not been as fully automated or has fully been taken advantage of for those clinicians. And then our last tool we're going to look at is our patient portals. So 4 times as many clinicians were in solo practice, small practice, and large practice, each 2 times as many compared to any other setting, and almost 2 times as many, and surprisingly, interestingly enough, in a medical school or an academic center. So when looking at specifically COVID-19 telemedicine, almost 70% reported using telehealth because of in response to the COVID-19 pandemic. The map on the left of this slide, really illustrates the variation in adoption rates of telehealth across our 4 states of interest. Again, that was Georgia, Kentucky, North Carolina, and Tennessee. 54% of clinicians reported their first use of telehealth due to COVID-19, as we can see here. Of those, 3 times, they were 3 times more likely to have been seen in their practice in 21 years or more, to be nurse practitioners and physician assistants or certified nurse midwives. Clinicians were 4 times more likely to be full owners of their practice if they used telehealth during the pandemic, but they were less likely to be in any other specialty than family medicine, in any other setting other than a federally qualified health center. And we can see some of those reasons for using telehealth. So the majority of them use it in response to treating COVID or negative or positive patients, for training purposes. And then others use it for chronic disease management, substance use, and mental health therapy. And so where are we going? Again, focus groups participants also indicated that patients face structural barriers to engaging with telehealth due to the lack of access to internet, such as Wi-Fi or broadband, the cost of telehealth equipment, and the lack of patient-clinician interaction. So we heard a lot that, again, telehealth is wonderful and it would help for patients to receive care, but they really desire that in-person interaction with their clinician. And again, you can see some of those supporting factors and barriers to adopting telehealth and telemedicine during the pandemic. So, widespread reliance on digital health tools and policy changes due to COVID-19 really served as a platform for the rapid response and adoption and improved access to telehealth, specifically in the Southeast and among racially, ethnic, and minority and rural communities. We heard that we need telehealth reimbursement for audio-only visits. The continued availability for clinicians to use their home as a presenting site, so allowing you all to work from home and be able to see your patients and also get reimbursed for that. And then also expanding, those geographic limitations that you all were facing. The upside, if we can find one in COVID-19, that we heard was that it provided opportunities to make telemedicine more accessible and more equitable. But again, we need those continued policy and practice changes to sustain and maximize this opportunity to advance health equity. So I'm going to turn it over to Rashira to talk about our Telehealth Disability Study. Thank you all so much.
Thank you, Mitchell, for that presentation. So I'll be doing the second half of some of our digital health tools study, and the study that we'll be focusing today, if you can go back to the next slide or the previous slide, please. Thank you. We will talk about assessing telehealth experiences to advance health equity for people with disabilities in Georgia in the post-COVID-19 pandemic. And so a little bit about this study. This study is being conducted through a partnership with the Georgia Council for Development of Disabilities. We were awarded a one-year grant to assess the adoption and use of telehealth and other virtual delivery services for people with disabilities. And this also includes family members and direct support professionals. And this was taking place during the COVID-19 pandemic. We have known that primary care practices, especially those in underserved communities, have struggled to adopt using digital health tools, such as electronic health records and telemedicine compared to other high-resource health settings. However, we did not know what these health tools look like and to the extent it has impacted the quality of care for people with disabilities. And so within the study, we basically employed a multi-method approach consisting of surveys and focus group with people with disabilities and their family members and direct support professionals in the state of Georgia. We've conducted a descriptive analysis of telehealth policies and interventions in the southeastern states related to access and the utilization of telehealth during the COVID-19 pandemic to inform Georgia policymakers that will advance health equity for people with disabilities in the state of Georgia. And so we conducted 6 focus groups with a total participants of 16, and we collected over 109 surveys. And 90% of participants respondents provided, they offered telehealth services, and 88% had telehealth visits since the beginning of the COVID-19 pandemic. And then 12% of respondents also identified in being Hispanic and Latino. And so in the slide here, we just have a few of the high-level demographics, such as the type of disabilities that were identified within the survey, as far as the enthusiasm behind people participating in the study as well. And so we see here that 31%, they were eager in adopting telehealth usage, 25% reported being skeptical and hesitant, and then 44% had a neutral response. And so a few quotes that we were taken from our focus groups that we conducted to basically assess how people were feeling as far as their interaction with telehealth services. Some respondents quoted, "Telehealth makes life easier for a parent of a child with so many needs. It's one less thing I have to worry about." And that was taken obviously from a parent with a child with a disability. And then a second quote was said, "Relationships matter with your telehealth provider, and the use of the patient portals to maintain health-related relationships is really important." And so we have here also participant self-identification, with a majority identifying as being disabled and then or a family member. And then as we see here in the second graph, we see the age demographic, which were a majority being between the ages of 21 to 29. And then we see 30 to 39, and then also 50 to 59. So we had a pretty good diverse age bracket there. Next slide, please. And then here, as we have our racial and ethnic demographics, with a majority of respondents reporting as being white, and then Black or African American. And then 5% of respondents identified as being Latino. And so then some of these other demographics, such as respondents who reported having health insurance, which reported at 86%, and 67% of respondents having caregivers or support personnel. And then respondents' insurance types also reported as 31 being on Medicaid waivers, 19 reported being on Medicaid waivers or the waiting list, or SSI reported for 24 respondents, and then caregivers, 45 reported as having parents, and then 21 reported as having siblings, and then 17 respondents reported as being direct support professionals, PCAs, and healthcare professionals. Thank you. And so in this particular slide, we have here the specific telehealth access and usage, in which 88% of respondents had telehealth visits with their doctors or another healthcare professional since the beginning of the COVID-19 pandemic. So we see there was definitely a high utilization and need for telehealth appointments. And then when we're looking at the specific type of technology that was used during their appointments, we saw that there was a high percentage of audio only, which included the phone, audio, and visual, and then a lot reliant on that 68 respondents and using computer, both audio and video components. And then when we're looking at the specific accessibility requirements, like it's really important when we're looking at this specific population group, people with disabilities, we see that 24% of respondents require additional services or supports due to difficulty in hearing. 14% respondents require additional services or support due to difficulty seeing, and 66 respondents reported were able to obtain such services during their telehealth visit. And so we see that some of the challenges and limitations surrounding telehealth utilization and the accessibility of using telehealth within that demographic group was also connected to accessibility purposes as well, and making sure clinician settings and providers were also able to support those accommodations as needed. And so for our telehealth, where people were located for their visits, we see that majority were located in a home, reporting with 93%, and then in doctor's offices, hospital visits as well. And so here's where we definitely see the implications on the need to allowing patients and providers to be able to provide these telehealth visits within the capacity of their homes. And then knowing if the visit was paid for by their health insurance company, we had 67% reported yes, that it was covered by their health insurance company, and then with 22% no, and then 11% unsure. And then more into the satisfaction, would they continue to use telehealth? Because that is not only one of the outcomes of the study, but to knowing, is this something that the study to inform Georgia policymakers in making this more a permanent solution, especially for underserved and at-risk communities, such as people with disabilities. We saw that 72% were more likely to use telehealth in the future, 17% unsure, and 11% unlikely. And then if they had not used telehealth services, we see some of the barriers and limitations listed here, which 6 reported telehealth was not offered by their provider. And then some, they weren't comfortable meeting online, and then they did not either have the right access to the technological requirements to engage in a telehealth appointment. And so as we go further into this presentation, we'll definitely give some highlights on what are the equity implications behind using telehealth and making sure that things such as digital literacy and policy implications are there to support people in the need that they need to use telehealth services. And so I'll hand it over to my colleague, Mitchell. Thank you so much.
Thanks, Bashira. So as Bashira said, there were some key implications and takeaways across both studies. So looking at our slide here, you can see there was high satisfaction with digital health tools, specifically telehealth across both studies. There is a need for increase in digital literacy and updates in technology. So going back to that patient need to have a more tailored experience, clinicians want to be able to offer that for patients. And those with disabilities need that need that tailored experience for their different conditions, and to support the individuals that they are serving if they are a family member or a caregiver. Permanent expansion of telehealth. So we saw that again across both studies. Reimbursement for our clinicians at the rate that they deserve, and at the rate that is equitable for the types of services that they are providing. There's a need for increased access to supports. So clinicians need support with the digital health tools training. They need support actually attaining the tools that they need in their particular practice. And people with disabilities and their support persons need access to, again, those digital literacy recommendations and supports, whether it's access to different hearing supports or visual aids. They need increase in access to those things. And finally, expanded broadband access, specifically for those living in rural areas. So across both studies, we saw that that was a barrier, both for clinicians being able to provide care and for our patients being able to actually receive care. So we just want to say thank you. Please feel free to follow us on our YouTube page. So we have a YouTube page that highlights both of our studies. So you can follow us at MSM, National Center for Primary Care. Follow us on Facebook at MSM NCPC. Our policy division actually has a separate Twitter, so you can follow us at NCPC_policy, where we highlight, again, a lot of our digital health tool study work in our telehealth disability study. And also you can follow the center at MSM NCPC and LinkedIn as well, also at the same handle.
Thank you so much, Mitchell. Before we go into the continuing education and what we offer here at iBridge, we have a few questions in the chat. So someone says, great work. Please discuss the differences in the adoption of telehealth when comparing rural and urban setting. What are the differences and issues presented by the providers and patients associated with their use of telehealth? What are some of the similarities in the issues presented in rural and urban settings?
Awesome. So thank you for that question. So across the rural and urban settings, again, there was some similar satisfaction with digital health tool usage, again, specifically going to utilizing telehealth. The barriers to addressing and implementing those tools were different across those two settings. So again, in our rural settings was the access to broadband, high-speed internet, dial-up, even access to having a reliable cell phone. So cell towers weren't very abundant in our more rural areas. In our urban areas, there's a lot more built infrastructure. So being able to obtain some of that needed infrastructure to have telehealth access or digital health tool access in general was a lot more abundant. Again, when we look at satisfaction is high, but clinicians in both settings need the same supports across both. It may vary. If you're in a large practice, you might have the support across multiple clinicians and have more infrastructure to really have your voice heard in decision-making and autonomy. But again, that in itself was a barrier and something that needs to be addressed and highlighted as well.
Thank you, Mitchell. I have a few more questions. Any data on what expectations or needs clinicians are seeking to address with their telehealth technology? What are some of the services or treatments would clinicians want to be able to do with telehealth technology?
Excellent question. So we don't specifically have that that we presented today in our study, but we have some of the questions that we dive in deeper into when we have a final report coming out. And we also have a COVID and telehealth equity report that we released that's also on our website. So clinicians are really digging into more post-pandemic, how can they utilize their technology in a more robust way? How can they start? Some are looking into artificial intelligence and machine learning. So how can they integrate that into their current setting? Patients still, as a whole, a lot of patients still aren't really ready to come back into the office. And so how can they still provide some of that same care? There's been an uptick in behavioral health appointments and care and specialty care being integrated into telehealth usage and remote monitoring as well. So clinicians are being very innovative and responding to the needs of their patients.
Okay, Mitchell, who were the internet providers, and how much hand-holding did patients need to utilize the online services, dashboards, templates, etc.?
So we don't have that detail of information, the actual providers. Yeah, so I can't answer that question specifically.
Okay, there's a few more. To what extent did the pandemic create a silver lining for advancing telehealth for people of color?
Great question. So again, telehealth made providing care more accessible, specifically in those underserved populations. And as Rashira mentioned, specifically with our patients with disabilities, a lot of those barriers for individuals was transportation, actually getting to and from appointments. And so telehealth really opened up a window of opportunity for them to receive care that they traditionally had a lot of barriers accessing. And so it really helped address a lot of chronic issues. Patients were able to get their medications at a higher rate than they ever were before in the midst of the pandemic. I want to make that clear. And so it really did provide a lot of opportunity for us, our underserved populations.
Thank you. Mm-hmm. So for practices who don't use telehealth, what was the biggest barrier for some of the practices that did not utilize telehealth during the pandemic?
So the biggest barriers, and we'll actually just go back to that slide.
Okay.
It really was, time. So we really, and I think it's slide 19. Thank you. So if we look at this slide, it's, specifically in the context of the pandemic, it was time. So the time to actually implement it, get it onboarded, get the staff trained. If you had never used before, you yourself as the provider have to get acclimated. And specifically one provider in our focus group, we had a very lengthy but fruitful conversation. Provider had used paper for over 40 years, never wanted to use technology, telehealth specifically. He was then mandated to use it in his practice setting. And so he had to get acclimated not using paper and paper charts anymore. So it takes time. Costs. A lot of these systems are very, very costly, specifically if you are a solo practitioner or in a private practice and now are implementing this.
Thank you. So did you find during that time, most of the providers implementing the telehealth, did the providers use scribes during their implementation?
That's a great question.
Is that something you can speak to?
That isn't. Okay. We didn't hear that in our survey specifically or in our focus groups.
In many minority communities, the providers are international physicians. So I am interested in how this may impact the use of telehealth.
So our study doesn't speak to that. So can I speak to that piece?
Okay. All righty. Thank you so much, Mitchell and Rashira, for that wealth of information that you provided today on those two studies. We appreciate you all joining our webinar. Just want to go over some services that we offer here for the providers. Format approved continuing education We partner with them for online continuing education to design and meet the needs of busy healthcare industry professionals by providing members with discounted trainings, continuing education, and professional development opportunities. These trainings are available for RNs, LPNs, physicians, PAs, clinical providers, consultants, managers, technology professionals, veterans, and others. If you're interested, reach out to us. We have our code here, HighBridge20, which you will receive a 20% discount if you are interested. Some of the upcoming learning opportunities we also have some trainings available from the Center for Leadership and Disability Training Opportunities, Georgia Statewide Disability and Health Program. If you are a provider or a clinician, you will receive CUs for participating in these trainings. The responsive practice is the first training providing health care and screening to individuals with disabilities. Responsive practice is the second training, accessible and adaptive communication. And also, if you're interested, we can email this out to you. This presentation will be available probably in a week. So all this information and the QR codes are on these presentations. Our upcoming webinar is April the 18th. Our webinars are every third Tuesday of each month. It's no cost to your practice to join these webinars. The next one is HIPAA and Security Risk Analysis 2023. So we will be providing updates on HIPAA and the Security Risk Analysis. Thanks again, Mitchell and Rashira, and everyone have a great day. Thanks again.
Thank you all.